start कीजिए. Yes.
Good morning everyone. Today I will be speaking on comparison of pre and post pterygium excision astigmatism and their visual outcome after cataract surgery. Nil financial interest. Pterygium causes visual problems due to induced corneal astigmatism or direct encroachment onto the visual axis. Corneal astigmatism can be reduced by pterygium excision surgery, which involves the use of several techniques like glue or sutures. Main objectives were to analyze the change in corneal keratometry and astigmatism after pterygium excision using glue and sutures. Secondary objective was to predict the outcome of toric IOL post-pterygium surgery. Methods: we had taken case records of patients underwent pterygium excision along with cataract surgery. Total 193 patients were taken. Uncorrected and best corrected visual acuity along with TANS pterygium grading we had done. Keratometry ratings pre-op and post-excision were taken. A-scan and all the cataract surgeries were done within 3 months of pterygium excision. 85 patients had conjunctival autograft with glue and 98 had with sutures. Pterygium grading, G1, T2, that is TANS grading, 21 we had taken grade 1, 133 grade 2 and 40 patients we had taken grade 3. Cataract grading, we had taken 172, 1 to 3 nuclear sclerosis patients and 6 were brown cataract patients, 15 were mature cataract. The mean duration between pterygium and cataract surgery was 1.5 months. SICS were done in 116 patients and phaco was done in 77 patients. Females were predominantly more. So coming to results, we have seen significant reduction in mean corneal astigmatism after pterygium surgery, which is comparable to study conducted by Garg et al. Mean uncorrected visual acuity was less than 6/60 before pterygium surgery and improved to 612 or better. In this bar chart, we can see approximately 97 patients had reduction in less than 1 diopter. 1 to 2 diopter we had seen 50% and more than 2 diopter again to 90%. Coming to results again, uncorrected visual acuity and best corrected visual acuity in pterygium patients pre-excision. So 660 were seen in 660 to 360 were seen in 90 patients. Then this bar chart shows post-pterygium surgery, best corrected visual acuity and post-cataract surgery both. So approximately 160 patients had better 6/12 results, 6/12 vision, and post-cataract surgery approximately 100 patients had better vision. Discussion. A study by Mishra et al. Shows that pterygium excision before cataract surgery enables significant improvement in vision and corneal astigmatism and enables accurate biometry preoperatively. As exact astigmatism by pterygium cannot be made out, in our study, phaco with toric IOL was performed in 16 patients after excision to evaluate the visual correction. Mean reduction in astigmatism was seen to be 1.31 diopter with toric IOL implantation when compared to monofocal lenses. Out of 16 patients with toric IOL, 13 patients had 6/6 uncorrected visual acuity and 3 had 6/9. Out of 16, 15 patients had grade pterygium. Hence, we can conclude toric IOL is quite effective in reducing the astigmatism post-pterygium surgery. Whereas in monofocal lenses, 61 patients out of 61 patients, 10 had grade 1, 45 had grade 2 and 6 were having grade 3. But the visual acuity uncorrected was 612 in majority of patients. No one had 6/6 vision. Conclusion: phaco with toric IOL implantation for visually significant cataract was a safe and effective procedure in post-pterygium surgery. It decreases astigmatism and superior visual outcome. Limitation of our study is retrospective, small sample size, surgeries were performed by different surgeons and outcome is questionable in advanced pterygium due to inherent scarring. These are my references. Since this was a retrospective study, we are doing the same study prospectively.
So it was good study, but what I see is there are some cases that were done SICS and some were phaco. So that comparison is quite difficult between the two.
Yes, sir. So phaco only we had phaco patients only we had seen.
For astigmatism.
For toric IOL,
But you didn't include those SICS because you mentioned it. Some
Yes,
were
sir.
SICS, some
It's a huge study, sir. We have taken many variables are there. We have taken selected one, like sutures and glue is also there. So, like we had seen with sutures after 6 weeks, how reduction is there. But again, with glue, astigmatism is less.
but that is not mentioned. Suture and glue distinction is there.
It's a part of the study. We have taken only one part of the study, sir. Here. So, SICS alone, we had seen reduction. That is also there. That 1 to 2 diopter alone has combined both SICS and phaco. But toric IOL, phaco toric.
And how long did you wait for the from the pterygium excision to the surgery?
Yes, sir.
How many weeks?
Within 3 months, like different patients, 3 months. So mean was 45 days approximately. It was different patient. It was a retrospective, sir. So whatever patients, whenever they had come, we had operated.
And not more than 3 months.
No, no. So that
Because studies say that if you wait for 6 months, the astigmatism stabilizes in a better way. So that if you are using a toric IOL, that would probably give a better results. But since your results are also comparable, I think what many studies show that they wait at least 3 to 6 months. So as to get to give time for cornea to get back to the normal.
Thank you, Dr. Yadav. Next presenter is Dr. Nikita Sharma. CDA. Nikita Sharma. Okay, we'll go on to next Dr. Meghna Mathur. Please come. Yeah. Dr. Mathur, you can start your presentation.
Good morning to all. I will be presenting on evaluation of prognosis of chalazion with triamcinolone acetonide injection compared with incision and curettage. Chalazion is a chronic non-infective lipogranulomatous inflammation of the bone gland. When the viscosity of the secreted lipids and proteins medium increases with age, hormonal disorders or environmental factors, medium accumulates in the gland's duct. This plugging of gland leads to swelling. When this swelling becomes persistent in nature, it is termed as chalazion. There are a variety of options for the treatment of chalazion, including incision and curettage, carbon dioxide laser, intralesional steroid injection, botulinum neurotoxin type A injection, and thermal cautery or total excision. Most widely accepted techniques are incision and curettage and intralesional steroid treatment. Aim to compare the effectiveness of intralesional triamcinolone acetonide versus incision and curettage in the treatment of chalazion. My objective is to compare resolution of chalazion with intralesional injection of triamcinolone versus incision and curettage. Material and methods. Randomized controlled trial, we took 60 patients with chalazion. Chalazion measuring up to 2 mm to 7 mm in size was taken. 2 study groups were made, one with triamcinolone acetonide, which included 30 patients, and other with incision and curettage, which included 30 patients. Both groups were further divided depending on size of the lesion, with 2 to 4 mm with 15 patients and more than 4 mm 15 patients. In triamcinolone acetonide injection of 0.1 to 0.2 ml of triamcinolone 40 mg per ml solution through conjunctiva is given. 26 gauge 1 cc tuberculin syringe is used. It has the advantage when treating children, patients having local or systemic allergic reactions to anesthesia, as well when having chalazion closer to the lacrimal drainage system. In incision and curettage, topical paracaine was added to the eye. 1 to 1.5 ml of lignocaine with 1 to 1 lakh epinephrine is injected beneath the orbicularis muscle through the skin root over the chalazion site. A chalazion clamp is inserted so that its circular opening surrounds the conjunctival aspect of the chalazion while its blade lies against the skin surface. Number 11 Bart-Parker blade is used to incise the tarsus vertically up to 3 mm over the area of chalazion. The curette is used to scrape out the cyst, tarsus and orbicularis surface until the entire content and wall of the cyst is removed from the internal lid. This is the procedure. Result. Patients were equally distributed with respect to size of the lesion in both the groups. Each group had 15 patients between 2 to 4 mm, while other 15 had size more than 4 mm. Of total 60 patients, complete resolution was observed in 91.7% patients, of which 90% were of group 1, while 93.3 were of group 2. It was observed that overall patients who underwent incision and curettage showed slightly better results than who were given intralesional triamcinolone acetonide injection. We observed that resolution rate in small lesion was better in patients who were given triamcinolone acetonide injection, while patients who had size more than 4 mm, resolution rate was better with incision and curettage. Discussion. In present study, we found that the lesion less than 4 mm respond well to triamcinolone acetonide injection than INC, while lesions which are more than 4 mm have better outcome with INC. This study supports previous studies and showed that triamcinolone injection may be a good alternative to incision and curettage in primary chalazion when diagnosis is straightforward and no biopsy is required. Treatment by injection is simpler and less inconvenient to patients, although the eyelid injection may be somewhat painful. The result of the present study were in accordance with the study conducted by Simon et al. And Goala and Associate. It was in contrast with the study conducted by Jacobs, who showed that higher cure rate by incision and curettage had a statistical significance value. Conclusion. From this study, we concluded that size less than 4 mm, we prefer intralesion injection, and size more than 4 mm, we preferred incision and curettage. These are the references. Thank you.
So, is this about only single injection or you have given multiple also?
Single injection.
Only single. So you didn't use in those that didn't resolve with single injection.
No, so that was a weakness we didn't use.
Right.
And how long did you wait for the chalazion to resolve before you could switch it to the incision? All of them resolved in your
90%
study?
of them resolved.
And how long did you wait? How much time did it
We
take?
waited for 3 weeks and the patient came for follow-up.
It resolved in 3 weeks, most
Yes,
Thank you.
with the injections.
Thank you, Dr. Mathur. Dr. Afrin Bari, she's here. Okay. Dr. Vigyata Goyal, also not here. Dr. Shavya, please.
Good morning, everyone. Today I'll be presenting on the topic
Just a minute. Now you can start.
to assess the efficacy of moisture chamber goggles in the prevention of exposure keratopathy in patients in the intensive care unit. No financial disclosure and ethical clearance is obtained. And coming to the introduction, exposure keratopathy is damage to the cornea that occurs due to the prolonged exposure of the ocular surface to the outside environment, and it can lead to ulceration, microbial keratitis, and permanent visual loss from scarring. And several factors help maintain tear film intact, which like intact blink reflex, normal blink rate, complete eyelid closure during sleep and blinking. And in critically ill patients, these protective mechanisms are challenged. These are some of the ocular conditions seen in the ICU, and lack of timely intervention may lead to the conditions like corneal ulcer and even blindness. Purpose of this study is comparing efficacy of using combination of ocular lubricants and lid taping with the use of moisture chamber goggles to prevent exposure keratopathy. This is the literature review where some of the articles said that moisture chamber goggles are efficient than the lid taping group. And coming to the methodology, it is a randomized controlled trial done at MS Ramaya Medical College and Hospital during the period of November 2023 to July 2024. And 62 sample size were taken, where 31 were cases and 31 were controls. And moisture chamber goggles, materials used for moisture chamber goggles, lubricating eye drops, micropore tape. AC vent and the position of the bed was also considered to monitor the atmospheric conditions. And the atmospheric conditions across all the beds was titled to be similar. Comatose patients with reduced blink reflex, patients of muscle relaxants, and mechanically ventilated patients with low GCS score, and the patients in ICU for at least 24 hours are included. And eye treatment with topical agents other than the lubricants, and patients with pre-existing trauma or inflammation to the eye were excluded. Coming to the procedure, 62 patients were grouped to 2 groups, one receiving lubricants and lid taping labeled as open chamber, and the other with goggles labeled as closed chamber. And detailed eye examination was done, like lagophthalmos, Bell's phenomenon, blink rate, pupillary reactions, corneal changes using 1% fluorescein under cobalt blue filter in direct ophthalmoscope. Corneal staining was done and graded, and cases and controls are followed up till they are out of intensive care unit. And 2 groups are compared with respect to conjunctival injection corneal staining, and data analysis is done using SPSS data, and results are documented. These are some of the pictures where we have put moisture chamber goggles. In the first picture, you can see the humid environment which is created. And these are the corneal staining pictures. And coming to the results, age and sex matching was done, where predominantly males were more, and 89% majority were 50 to 90 years of age group. Coming to the results, conjunctival injection, we have compared on day 1, day 3, and also the final day, where final day 29.2% were mild and 14.5% was diffuse in closed chamber and in open chamber, and in closed chamber it was 32.1% mild congestion and 17.7% was diffuse congestion, where p-value on day 3 was 0.21 and final day 0.24, which is insignificant. And coming to corneal staining, final day it was 84.6% in no staining, and some staining was 11.5%, and closed chamber it is 78.8% no staining and some staining was 19.2%, and the final day it was 0.24 for p-value, where it is insignificant. And the discussion, in our study the use of moisture chamber goggles were equally effective compared to the open chamber group, and is also considered as less tedious job to the nurses working in the ICU, and instructions given to the staff in the ICU was less time consuming and more efficacious from doctors and nurses' point of view. And moisture chamber goggles, they provide a sealed environment around the eyes, maintaining humidity and reduced evaporation, and it helps in enhanced moisture or tear retention, humidity control, protection from irritants, ease of use and improved healing. And according to these references, only the conducted on nurses, 21% of nurses had good practice, 25.7% had good practice in improving eye care, and 28.9% had fair practice. And according to Khalil et al., 59% felt it was lack of knowledge, where 19% felt it is an important job, not an important job. And according to this study, we have done a study at our center where lack of knowledge accounted for 59% and lack of time was 4%. Too much work was 6% and too much documentation was 19%. Coming to the conclusion, moisture chamber goggles are equally effective in preventing exposure keratopathy and reduces the need for constant intervention and follow-up on correct application, unlike in lid taping. And the ease of use and equal benefits with less efforts shows that moisture chamber goggles play an excellent role in preventing exposure keratopathy in critically ill patients where ocular treatment is compromised due to various reasons. These are my references, and thank you. Through their eyes, we have witnessed both fear and the will to fight. And these are the moisture chamber goggles which is used.
Yes, Dr. Shave, what is the cost of these goggles?
So it is like around 150 to 180 bucks on average.
Rupees, that's all.
Yes.
Thank you, Dr. Shave.
Thank you, sir.
Now, Dr. Rohit Kumar Gupta is available. Okay, it seems Dr. Afrin Bari has come. Are you ready, madam?
I'm very much
Okay. Dr. Simran? Not come. Dr. Kavana K. Murthy?
I'll be talking about topical cyclosporin eye drops, 0.09% in severe dry eye prior to cataract surgery in rheumatoid arthritis. Rheumatoid arthritis is a systemic autoimmune disorder connected to ocular disorders such as corneal inflammation and lacrimal gland destruction that leads to dry eye and corneal staining. The occurrence of post-operative corneal melt is a devastating complication seen in rheumatoid arthritis if the inflammation is not under control. The purpose of this study is to study the cataract surgery outcomes in severe dry eye and rheumatoid arthritis patients with topical cyclosporin 0.09% eye drops. What was the need for the study? In spite of systemic immunological mediators within normal limits and the rheumatologist consultation, the severe dry eye was still persistent in all these patients. So for local control of inflammation, cyclosporin 0.09% eye drops were started preoperatively and the effectiveness is studied. So what do we choose, SICS or phaco? We have selected phaco emulsification as the SICS wound is larger and induces more inflammation and may lead to scleromalacia. This is a cross-sectional observational study done in ophthalmology department in Ramaya Medical College Hospital. Inclusion criteria: all patients diagnosed with rheumatoid arthritis, severe dry eye with Sherman's less than 5 mm, T-but less than 10 seconds, and all patients are undergoing temporal clear corneal phacoemulsification with IOL implantation. Exclusion criteria: any other ocular surface disorder leading to dry eye, previous ocular surgeries, patients on any long-term medications. We have included 3 patients, detailed ophthalmic evaluation with dry eye evaluation is done, Schirmer's test, tear film breakup time, Oxford grading for ocular surface stain. After complete pre-op evaluation, the patients were found to have severe dry eye and surgery was deferred. Then these patients were started on cyclosporin eye drops 0.09% TID, and the immunologist opinion was again taken for adequate immunomodulation. After 1 month, Schirmer's test improved and the ocular surface stabilization was achieved, and the patients were taken for cataract surgery, and the outcomes are studied. The case 1 is a 40-year-old female patient, case of rheumatoid arthritis, referred from immunologist with complaints of diminution of vision with visual acuity, counting fingers at 2 meters. Cornea, there were minimal staining according to Oxford staging of staining. There was immature cataract NS3. Schirmer's test was 0 mm and T-BUT was 2 seconds preoperatively. After 1 month of starting cyclosporin eye drop 0.09%, Schirmer's improved to 10 mm and T-BUT stabilized to more than 10 seconds. Post-operatively also it was maintained. This is a case 2, 60-year-old female patient, known case of rheumatoid arthritis, again referred from my immunologist with diminution of vision, with visual acuity 660. Anterior segment, there were punctate staining on the cornea and conjunctiva with immature cataract NS2. Schirmer's was 0 mm, T-BUT was 1 second preoperatively. Starting on cyclosporin eye drops for 1 month, Schirmer's increased to 10 mm, T-BUT more than 3 seconds and was maintained post-operatively. And there was clear cornea. Case 3, 80-year-old female patient, known case of rheumatoid arthritis, came with sudden complaints of diminution of vision and in the right eye and sudden onset pain. She gives history of right eye cataract surgery, that is SICS, done 1 month ago. Right eye, on examination, the vision was counting fingers half meters. Anterior segment, there was corneal thinning noted at 1 to 3 o'clock hours. Superficial vascularization was present. Circumcorneal congestion was present. Pupil sluggishly reacting. PCR is in situ. This patient was diagnosed with corneal melt and underwent corneal gluing with bandage contact lens. After 2 to 3 months, there was reepithelialization noted in the areas of corneal thinning and the right eye was stabilized. Considering this patient as a one-eyed patient, we decided to take her for a cataract surgery for the other eye. The vision was counting fingers 3 meters and immature cataract was present. On evaluation, left eye, again Schirmer's was 3 mm and T-BUT was 5 seconds. After starting cyclosporin eye drop 0.09%, Schirmer's stabilized to 20 mm and T-BUT more than 10 seconds, and post-operatively also it was maintained. Discussion. The first, Pragya et al. Talks about the visual outcomes and complications in dry eye disease following cataract surgery. Here the results were visually, visual outcome was significant. In the second, Young Chung et al. Here they have spoken about the effectiveness of cyclosporin 0.05% post cataract surgery, and they told after using for 2 to 3 months the ocular surface was stabilized. So conclusion, rheumatoid arthritis associated corneal melts have significant ocular morbidity and requires early and aggressive treatment. Integrated approach to systemic diseases along with immunologists gives compromising results, so timely diagnosis and preoperative approach to dry eye is very important. Using cyclosporin with steroids and lubricants reduces the complications like corneal melt. This is the conventional what we use, 0.05% cycloimmune and ristasis emulsion. This is SICWA, this is newly FDA approved, there is no conflict of interest, no financial disclosures. This is 0.09% what we have used in our study. So happy patient with tears and a happy doctor without tears. Thank you.
So this study was specifically for cyclosporin, or you were, the 1 month period you were using other medicines?
No sir, it's exclusively cyclosporin, but with lubricants, no steroids in it.
How long did you continue cyclosporin post-operative? How long did
Since we considered 0.09%, the drops which we considered was little on a costlier side. So we continued for 3 months post-operatively, sir. After that, we slowly tapered down to 0.05% cyclosporin.
And how long did you follow those patients up?
The patients are still following up. They are doing fine. The ocular surface is stabilized, sir.
If you have, what is the longest follow-up here?
This 1 year follow-up we have, sir.
What lubricants were you using?
Sodium hyaluronate.
So there's a difference in lubricants also, is it not? You have CMC, HPMC, sodium hyaluronate.
Yes.
So don't you think that makes a difference? So you have put all patients on cyclosporin and sodium hyaluronate.
Yes.
How much is sodium hyaluronate? What is the cost?
Around 4.
Isn't this a costly study to be doing on patients? Do you think all patients can afford that?
Yeah, that was one drawback of our study, but we wanted to try with the better lubricants which had less frequently, which can be less frequently used.
Okay. Thank you, doctor. The next, Dr. Tultul Das. Please come.
Good morning, everyone. Today I will be presenting my topic on my paper on the topic the effectiveness of topical tacrolimus eye ointment 0.03% in treating refractory allergic conjunctivitis. Coming to the introduction, allergic conjunctivitis is a type 1 immediate hypersensitivity reaction mediated by degradation of mast cells in response to IG. The routinely used eye drops containing antihistamines, mast cell stabilizers, or a combination of both are being used for treatment, and if the action is not sufficient, steroid is being added. However, steroids has some complications like secondary infections and the glaucoma, cataract when used for long durations. So tacrolimus is an alternative in treating cases refractory to routine anti-allergic medications, including steroids. It is a macro derivative calcineurin inhibitor with anti-inflammatory and immunogenic property. It suppresses the T cell activation and interleukin 2 production. Coming to the aims and objectives, to assess the effectiveness of tacrolimus as an eye ointment in refractory allergic conjunctivitis. Materials and methods. This was a prospective study carried out in Tertiary Care Center located in southern Assam. The duration of the study was from 6 months, from December 23 to May 24. The clearance was taken from the committee. The number of subjects that were included were 27 with refractory simple allergic conjunctivitis whose condition had not improved with traditional anti-allergic eye drops and steroids were included in the study. Coming to the inclusion criteria, male and female patients above 5 years with refractory allergic conjunctivitis. Those who have given consent for the study, and in the exclusion criteria we have included pregnancy, lactation, history of herpetic eye disease, ocular and infections with lead abnormalities, high IOP, hypersensitive macrolides, patients without consent. Coming to the methodology, the patients were examined for visual acuity, slit lamp examination of an anterior segment, intraocular pressure was measured by government accredited chronometer, and post-assessment was examined by ophthalmoscopy. At the time of enrollment, the current ocular therapy was stopped. For 4 weeks, 0.03% tacrolimus ointment was administered twice daily to the affected eye. This was followed by a 2-week drug-free period. Patients were followed up in the first 4th and 7th week. Patients were given some scores as 0, 1 to 3 on the basis of severity, as none, mild, moderate, severe, respectively. Coming to the signs and symptoms, this is scoring that has been done based on the signs, based on the intensity of the severity of the symptoms and signs. Like for photophobia, we have given 210, and for intense photophobic none. For itching also 210, and same with the same way we have given scoring for different symptoms, signs and symptoms. This is the clinical scoring based on the clinical scoring which have come out with. During the study period it was 7 to 14, and at the first week it was less than 7, at the 4th week it was less than 5, and at the 7th week it was 0. This is the bar diagram showing the total scoring at the end of various weeks during the study period at the first week, at 4th week, and at 7th week. And this is a scoring based on the which is in comparison with the which refers to the age and sex distributions. Coming to the results, at the end of first week, the signs and symptoms of simple allergic like itching, watering, and photophobia were significantly reduced. All the cases were fully cured. At the end of 4th week, all the cases were fully cured. All patients advised to discontinue 0.3% eye ointment. And there was a drug-free period of 2 weeks. At the end of 7 weeks, all patients were re-examined. None had any signs and symptoms of allergic conjunctivitis. Coming to the discussion, ocular allergy disease is a common problem affecting about 20% of the population worldwide. So, 0.03% tacrolimus eye ointment is found to be effective, safe, and well tolerated in the treatment of intractable allergic conjunctivitis. The most common side effects of tacrolimus eye ointment is transient foreign body sensation, burning sensation in the affected eye, and blurring of vision. But compared to steroids, it doesn't increase IOP. Coming to the conclusion, hence from the study, it can be noted that 0.03% tacrolimus eye ointment is very effective, safe, and well tolerated in treating refractory simple allergic conjunctivitis. In comparison to steroids, it doesn't increase IOP. So hence it is an excellent alternative to anti-allergic and steroid eye drops. Moreover, the potential of 0.3% tacrolimus eye ointment to reduce the incidence of recurrence is desirable. These are my references. Thank you, sir.
So how long this study was followed? Because the allergic conjunctivitis is very notorious for this.
Yes, we did a study for 6 months. Sir. It is
So you used tacrolimus for how long?
First, sir, we for 4 weeks, sir, twice daily it was given. Sir.
And then you stopped.
Yes.
And then again you followed after?
Then we have all the patients at the first week, at the 4th week, and the 7th week, sir. Four weeks.
How do you claim that you said after one month all the patients were cured?
So
That's
based on
what you
observation,
mentioned.
based on the signs and symptoms that have reduced, sir, but in the
You
clinical
can't say
scoring,
cured.
sir.
You had mentioned that all the patients after 1 month were cured.
This was already, many patients were cured, sir.
This doesn't cure it. This will happen.
The
You
symptoms
stop
were
medicine,
almost cured, sir. Symptoms were reduced almost, sir, usually.
You mentioned twice that all the patients were cured.
Did any patient develop any side effects from tacrolimus?
No, sir. Like there was a prevalence of burning sensation were there, and no other complaints other than that.
No congestion, nothing.
Sir.
No increase in congestion of the eye, no swelling.
There was hyperemia, but it has subsided, sir, afterwards.
How long did it take for the patient to account? Because tacrolimus causes irritation.
Irritation is,
How you motivated patients to continue up despite irritation and all that?
No, we have asked the patient to continue because we have explained the patient that it will subside with time. So so we have asked the patient to continue it.
And did you add any lubricant? Because
Yes,
all
sir.
the allergic conjunctivitis
Yes, so
patients
we
have
have added
noticed
carboxymethyl
having
cellulose.
dry eye. You
Carboxymethyl
only,
cellulose.
you added tacrolimus plus
Carboxymethyl cellulose.
and nothing else.
Thank you, Dr. Das. Dr. Afrin Bari, please come.
Good morning, everyone. I am Dr. Afrin Bari.
Wait. Yeah, no, stop. Okay, fine.
I am Dr. Afrin Bari, clinical scientist at RP Center, AIIMS, Delhi. I will be presenting on clinical outcomes of minor salivary gland transplantation in cases with severe dry eye disease following Stevens-Johnson syndrome. This will be the outline of my presentation. Stevens-Johnson syndrome is a complex immunological disorder, dermatologically separating it from toxic epidemiological necrosis. It involves less than 10% of the body surface area. However, it predominantly involves the oral mucosa and conjunctiva. There are very few options in cases with very severe keratinization. One of them is minor salivary gland transplantation. Now, where to take the minor salivary glands from? They are present in large numbers in the label, buccal and palatal mucosa, and there are limited studies in literature on the outcomes of MSGT in chronic SJS. My study was an introspective interventional case series. It was done at RP Center for Ophthalmic Sciences. The inclusion criteria was patients with severe dry eye disease following chronic SJS. There was severe aqueous deficiency in the cases that were included with Schirmer score less than 5 mm. In cases with bilateral involvement, the eye with the worst parameters was taken and a minimum follow-up of 1 year was included. The cases which had active infection, ulceration or perforation at the enrollment were excluded, and those who were not willing to follow up were also excluded. All the cases were graded pre-operatively and 1 year post-operatively based on the grading criteria published by Sharma et al. This is how the procedure was done. This is how the graft was harvested. Pre-operatively, the patient was asked to do beta-glutin or chlorhexidine gargles. After cleaning the oral mucosa with betadine, a marking of approximately 10 into 10 was done, and after infiltrating lignocaine and adrenaline, dissection was done of the graft. It was ensured that it was done at a deeper level so that the glands are sufficiently taken. Thereafter, using the pressure as well as cautery, the bleeders were stopped and the area was closed, buccal mucosa was closed with polylactin suture. Thereafter, the cotton was put so that there is no bleeding, excess bleeding. Now, when for doing the transplantation. Earlier, we followed the technique of transplanting it to the superior rectus muscle. Firstly, so after superior peritomy, the superior rectus was hooked and brittled. It was identified with brittle. Thereafter, the gland was placed on the muscle with the mucosal side down, and it was sutured to the superior rectus muscle such that there was a gland superior rectus complex with the mucosal side towards the superior rectus. Thereafter, the rest of the conjunctival closure was done. Post-operatively, the patient was asked to put topical antibiotic moxifloxacin steroids, which was prednisolone phosphate, and lubricant drops. For the oral part, he was asked to use betadine or chlorhexidine goggles. Now the results was, we included 20 cases, 12 females and 8 males. Coming to the main results, there was improvement in the Shermer, hyperemia, conjunctivalization, keratinization, neovascularization, palisades of Vogt score, corneal opacity score. All were less than 0.05. As you can appreciate here, cases with very severe dry eye disease and keratinization were included, and 1 year post-operatively, there was marked improvement in the ocular surface. This was how they were on subsequent follow-ups. This was how the staining was also recorded. Now MSGT, it is a procedure which improves sweatability and reduces inflammation, which improve objective scores. The advantage is that there is biosimilarity between tear saliva and oral mucosa conjunctiva. It is always easily accessible and universally available with no risk of rejection. It is a low cost simple technique and can be repeated. The limitations of the study was the quality of analysis of the subject was not done, and lack of immunochemistry to see the saliva, how it came out after the implantation. To conclude, it is a viable and effective technique, and in future, RCT would enhance the understanding of the disease. However, it would be very difficult to conduct an RCT in cases with SJS because of the rarity of the disease and numerable factors which are involved in the natural history. Thank you.
Thank you, doctor. Questions?
You said you put the gland, the buccal mucosa, mucosal surface down. Mucosal surface down means towards the rectus muscle or toward facing the conjunctiva?
Sir, the buccal mucosa, that
The
salivary
graph.
gland,
Yeah.
the gland was towards the superior rectus muscle.
Okay, that's right, because you said mucosa towards the spine,
Mistaken,
but
yes.
showed it
Yes,
there.
yes,
It has to be, the glands have to be, because they have to get the blood supply from the rectus
Yes.
muscle.
Okay, thank you, doctor.
Thank you, sir.
Is Dr. Nikita Sharma here? Dr. Vigyata Goyal? Dr. Rohit Kumar Gupta? Dr. Simran? Okay, thank you all.